It's Felix Böhm, and I work at Danderyd Hospital, the Karolinska Institute in Stockholm, Sweden. Patients with acute myocardial infarction and multi-vessel disease, they are at increased risk of serious complications. It's long been unclear what is the best strategy for the non-culprit lesions, so vessels narrowings in other parts of the heart. So the strategy to do what to do with those vessels, that's been unclear. So the study was performed as a multinational RRCT hybrid, registry-based randomized controlled clinical trial. So in 32 hospitals in 7 countries, and all the patients in Sweden were actually randomized directly in the registry, and some of the data was also collected from the registry to the database. And in other countries in the study, in Denmark, Serbia, Latvia, Finland, Australia, New Zealand, they were randomized through a separate web page, and then all the data was merged into the full REVASC study database. And the patients that were included were 91% STEMI and 9% very high risk non-STEMI, and all had to have multi-vessel disease, so with at least one more non-culprit lesion, at least 2.5 millimeter in diameter, and with 50 to 99% stenosis grade. And then they were randomized in a one-to-one fashion to either FFR-guided PCI of all non-culprit lesions, sometime during the index hospitalisation, or to initial conservative management of all non-culprit lesions. And then they were followed for a median of 4.8 years until we had 304 primary outcome events. Well, the key findings are the following: that there was no difference between the study groups in the primary combined endpoint of all-cause mortality, new myocardial infarction, or unplanned revascularization. And the p-value was 0.53, hazard risk ratio of 0.93. And also the key secondary endpoint of death and MI did not differ between the study groups. And the key secondary endpoint of unplanned revascularization did not differ significantly between the study groups. However, there were numerically fewer events in that endpoint by the complete strategy. And as a secondary endpoint, the combination of planned and unplanned revascularization was significantly reduced by a hazard ratio of 0.59 by the complete strategy. We had furthermore one secondary endpoint, the combination of cardiovascular death, MI, or unplanned revasc, and that was actually not significant either, but numerically fewer by the complete strategy. So those are the main endpoints. Our study results must be put in perspective with other large recent trials, like the COMPLETE trial and the FIRE trial, where they both showed a clear reduction in hard clinical endpoints like cardiovascular death or new MI. Our results were quite neutral in terms of hard endpoints, but we could avoid repeat revascularization. So I would say that our study results, they complement the previous studies, and at least in our study we did not see any clear effect on hard endpoints. So I would say that this means that you sometimes, if there is a circumstance that makes a complete revasc complicated, that perhaps you can wait and only treat the patients if they come back with angina, because good news is that most people actually are doing well regardless of the strategy we choose, at least in our study. And if they come back with angina, we could of course help them. So I would imagine that we would still aim for a complete revascularization, taking all the other studies together. But if there is a complication or if there is some circumstance that makes it difficult, then you can wait. Well, the key message is that a strategy of FFR-guided complete revascularizations in patients with STEMI and multi-vessel disease was not superior to a strategy of culprit-lesion-only PCI in reducing the combination of all-cause mortality, myocardial infarction, or unplanned revasc at a median follow-up of 4.8 years. The Complete-2 trial is an ongoing study which is led from Professor Shamir Mehta in Canada, and it's comparing, we're also taking part in that in Sweden, and that's comparing complete revascularization as determined by visual estimation of stenosis grade in one arm to FFR-guided or physiology-guided complete revascularization in the other arm, and that will include over 5,000 patients with both STEMI and non-STEMI. In that study, there will also be, and other studies as well, an OCT sub-study, so we can see also whether vulnerable plaques play a role here, if we should treat them or with preventing stenting or not.